Good afternoon, ma'am. I would like to start the session now. So, warm welcome for the LMHI Global Colloquium 2021. Today's session would be on case reports, observational, pragmatic, and randomized control trials. I would request all of you to abide by your time slots given to you for 15 minutes presentations. And I would request you to keep the questions and answers very brief so that everybody can finish their presentation on time. I would now over to Dr. Anu Rajesh. Please, could you introduce everybody here?
Thank you. So we are beginning our second session. Today we have Dr. Josh Matthew from Nehru Homeopathic Medical College and Hospital, Delhi, Associate Professor, Department of Materia Medica, to chair this session. So may I invite our first speaker, Professor Shubhamal Ghosh, to present his study on efficacy of individualized homeopathic medicine in primary dysmenorrhea. Over to you, sir.
And what is about my PPT? Is it visible?
Yes, it's visible. You may continue.
Yeah. So, respected chair and coordinator and the moderator and the respected audience. Before starting my session, I like to say the scenario of homeopathy till date. See, the meta-analysis of Robert Matthew in 2014, it says, very interestingly, individualized homeopathy may have small specific treatment effect, that is odd ratio is 1.53. Second one, that is the key message to the audience, is the low unclear quality of evidence. Yes, so this is the key message to me also, and we have adopted this message that we have to create some evidence in homeopathy. That's why we have tracked out few gray areas of homeopathy where we can do something. So we have chosen a very easy clinical phenomena, that is primary dysmenorrhea, keeping in mind that we have tried to conduct future trial on premenstrual syndrome as well as PMDD, that is premenstrual dysphoric disorder. Keeping in mind already this trial under channel. So very important is efficacy of individualized homeopathy medicines in primary dysmenorrhea. This is our title, a double-blind, randomized placebo-controlled clinical trial. Why we have chosen the RCT double-blind randomized control trial? Because this is the hierarchy of the evidence-based medicine. Yes, it is very important. It is a gold standard of efficacy in homeopathy. So we have chosen double-blind randomized placebo. It's very difficult to address double-blind randomized control trial in homeopathy because there is a chance to deviate from the individualization. So keeping in mind that homeopathy principles should be restricted, homeopathy principles should be maintained, we have conducted successfully this trial in Mahesh Bhattacharya Homeopathy Medical College and Hospital, which is a postgraduate homeopathy medical college in West Bengal. So these are our co-authors and the researchers. 1 minute. So next slide is visible. Moderator, is it visible to the slide? Next slide. Okay,
yes,
fine.
sir.
So yes. So this is our paper already published in the PubMed-based research journal in 2021 June. So it is already published. So what was the background of the primary dysmenorrhea? See, dysmenorrhea is a very common phenomena in menstrual women, menstruating women, which incapacitates daily activities of a woman. So it affects the quality of life also. That's why primary dysmenorrhea we have included in our study. So definitely there are 4 types of dysmenorrhea: primary dysmenorrhea, secondary dysmenorrhea, membranous dysmenorrhea, and ovarian. So we have excluded that. So this is the classical definition of the operational definition of the primary dysmenorrhea, which is depicted here. Very important one is that this pain, this excruciating suprapubic pain, is produced by the prostaglandin E2 and the others pain releasing substance, and specifically in cases of PMS and PMDD, some neurosteroids is also responsible, that is allo. So we are not just discussing here. What methods we have adopted? Already I have told: double-blind randomized placebo-controlled 2 parallel arms, and setting of our college, that is Mahesh Bhattacharya Homeopathy. That is our previous posting. I have shifted to Jindal Homeopathy Medical College nowadays. So this is the gynecology OPD, and the sample size was calculated because there are few studies already done in primary dysmenorrhea. One is in Iran, Tarbej Medical University. They have conducted one trial on primary dysmenorrhea, but they didn't show any significant effect of homeopathy in primary dysmenorrhea. That initiates that we have to do a good quality of clinical trial in primary dysmenorrhea. That is our challenge. The sample size was 218. We have calculated sample size from the prevalence, 2 into 64 each arm, and recruiters started in November 2018, and follow-up was completed in the February 2020. Randomization is a very, very important, in double-blind RCTs. There are 4 principles, which is called USP of double-blind RCT is very important, is randomization. One is a blinding, is the second, and third one is allocation and concealment. There are the 4 sponsored guidelines and the red hot, which is very standard guideline. Yes, randomization, stat-track random number was generated, 13 permuted blocks and another 1 randomization block. And blinding, double blind, the patients, yes, the patient is blinded, treating physicians is blinded, outcome assessors are blinded, pharmacist is blinded, and the data entry operator is blinded. So you see, it is completely blinded one. So very, very important in blinding. Otherwise, there are some biased coming. Allocation concealment, that is very important in double-blind RCT. Identically coded containers having LI vials coded indicated either of medicine or placebo, assigned randomly and confidentially. There are about 130 medicines are blinded as coded. More than 130, I think. Trial reporting, it compliance with the, already I have told, compliance with the consort and the red hot guidelines is a very, 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 very important message to audience. Yes, it's a very, what are the outcome measures? Yes, it's a very easy outcome measures we have adopted. 0 to 10 numerical rating scale, that is NRS, measuring intensity of the pain scale measuring we have adopted as a validated scale we have adopted. And the second one is the variable multidimensional scoring system, that is VMSS, assessing the severity dysmenorrhea associated symptom. This scale is very important because not only the physical symptoms, here the psychological domain is also incorporated in VMSS. So it covers the whole women in primary dysmenorrhea, which is very important message to homeopaths. So it includes the holistic approach. So we incorporated a VMSS scoring system. What are the, yes, we have adopted the ethical issues in Mahesh Bhattacharya Homeopathy Medical Colleges. There is a scientific review committee. After reviewing, they have given IEC, that is institutional ethical clearance. So it is very easy to get ethical clearance because primary dysmenorrhea, so placebo control is nothing worrying for the IEC member. So they gave IECs very easily. So that's why we have adopted a very functional disease. So ethical clearance in double-blind RCT is very difficult. Those who are conducting double-blind RCT, they know very well. It's a very, very challenging one. provision of treatment adverse event we have recorded, that is very important in the trial, and neither any new drug or nor any new treatment protocol adopted. So this is a very conventional drug we have adopted. For last 200 years, homeopaths are using those drugs. We have adopted same drugs. That is ethical consideration. And the patient information sheet in the local vernacular Bengali language, that is also is a very ethical issues. And written informed consent prior to the enrollment already done, and approval obtained from the IEC prior to the initiation of the study. So all ethical issue has been completed before the study. And yes, we have created CTRA registration. We have created CTRA registration before the study. What are the inclusion and exclusion criteria? Yes, mostly these primary dysmenorrhea is meant for young adulthood. It is a coverage. It is 18-20 schoolgirls. Study shows 80 to 90% schoolgoers suffering from primary dysmenorrhea. But sometimes it goes up to the above age. Sometimes 40 aged women may suffer primary dysmenorrhea, provided that secondary dysmenorrhea will be excluded by USG and other means. So we have considered age between 13 to 45 age. So that is, we don't miss any age group people. So literate and willing to give informed consent complying with the study procedure. This is the exclusion criteria. We have excluded all the pathologies which is included in the secondary group. Yes, that is intervention, experimental and Vera. That is the individualized homeopathy in the centesimal potency. So we have considered the centesimal potency and comparator and placebo, identical looking placebo group. So we have adopted the concomitant care, the psychological support. That is very important in the pain management, psychological support, assurance, and nutrition diet, adequate fluid and maintenance of the regimen of the hygienes. All are adopted. This is the consort flow diagram. This is a very, very important. We have to maintain this study flow diagram, but it is screened and as per eligibility criteria, that is we have screened 267 subjects and excluded 139 as per the exclusion criteria. So meeting the eligibility criteria, enrolled randomization for 128 and received individualized homeopathy, the 64 one, and the placebo one is the 64 one. So last to follow up, it is about 7 in both arm, and definitely endpoint analysis is intention to treat analysis. So we have adopted all the missing data also. So this is the study flow diagram. What are the results? That is a very interesting result for this study. Verum and control groups are identified as per the distribution of the confounder variables, and the difference between the groups in pain NRS and VMSS over first, third months favored in individualized homeopathy significantly against placebo. See, all p-value is the less than 0.01. That is that we have adopted 2 repeated measures of ANOVA here. And see, there are many medicines that come up as per the individualization perspective. It's a very common medicines, pulsatilla, Netramure, Calcarea carb, and Calcarea phos and phosphorus were the most frequently prescribed medicines are prescribed during the trial. This is the result. Significant changes in the pain in the NRS of this primary dysmenorrhea over the time, and significant changes in the VMSS over all score over time. See the significant changes in VMSS pain intensity score over time. See the significant change VMSS of the whole life, quality of life also. Significant changes in VMSS of physical symptoms as well as the psychological symptom scores is significant changes. So what is our conclusion? Conclusion is the group difference in pain NRS and VMFS favored in individualized homeopathy significantly against placebo at all the time points. So individualized homeopathy accepted significantly better than placebo in treatment in primary dysmenorrhea. So what is the key message to you, audience? Please replicate the same trial in your center to validate homeopathy is efficacious in primary dysmenorrhea or not. Thank you. Hope I have concluded my lecture in a
Thank you, Dr.
stipulated time.
George. May I invite Dr. George for his comments?
I'm not audible, Dr. Josh.
Dr. George, you have to unmute yourself.
Thank you, Dr. Ghosh, for your excellent.
Namaskar, namaskar, namaskar.
A few questions regarding, like you have mentioned about adverse events being reported. So, did you have any adverse events? How were they?
No adverse report during trial is not. Naranjo, we have tried to send the Naranjo protocol also, but during this trial we have not received any adverse report.
Okay. And like you mentioned in your inclusion that you have taken literate people, so that literacy as a guideline. So, is there any particular reason?
Actually, no reason. It's an ethical ICMR guideline, so we have to adopt they have to fill up the form, no? So that is important.
And the only thing is, like, if you keep that,
Yeah.
If you can have a person, like a non-biased person who can fill up for them, or like if you make it a illiterate person and a literate, like make a guideline or a differentiation based on that, I think you may miss out a part of it.
Yeah. So miss out.
That is one thing which I observed.
That is. Thank you.
And then why you focused on centesimal potencies? Any particular reason?
Because centesimal potency is very commonly, frequently prescribed by the homeopath. 50 millisimal potency is not used frequently by the practitioners. So we have chosen the very common phenomena.
Okay.
So we are trying to do in our further trial. We are talking about the PMS and the dysphoric syndrome. We're trying to incorporate centesimal as well as 50 millisimal also.
And your VMS's scoring?
Yes.
About, because that is something.
It's a validated scale, yes.
Yeah, that is actually, you have mentioned about the psychological
domain. Yes, so there are some psychological domains which is a very interesting one.
So in this study, did you come across any particular pattern in this?
Pardon? I cannot hear properly.
In this particular study, did you come across any?
Yeah. There are many symptoms come up, which initiates for our further trial, that is dysphoric syndrome. So not only the dysmenorrhea, there are some mood disorders, right? Depressions. We have noted here.
So that I think if you do a further trial based on this,
come
out with more data regarding correlation.
Yes, exactly, sir.
Okay. Thank you, sir. Thank you.
Thank you, Dr. George. May I now invite Dr. Munmun Kole to present efficacy of individualized homeopathic medicine in the treatment of hemorrhoids. Over to you.
Thank you. So good afternoon, everyone. Today my topic of presentation is study to evaluate the efficacy of individualized homeopathic medicine in treatment of hemorrhoids in the light of Hahnemannian concept, a double-blind randomized placebo-controlled clinical trial. I myself, Dr. Munmun Kole, postgraduate trainee from the Department of Organon of Medicine and Homeopathic Philosophy from State National Homeopathic Medical College, Lucknow. Okay. So before going to my work, I would like to discuss the all over world the scenario about piles. As we all know that piles is the fourth leading GI diseases, right? So about 3.3 million people of United States are suffering from this condition, but only 4% seeks medical help. In case of India, it is about 50% population who would have suffered from piles at some point in their life. A recent documentation research reported that hemorrhoids is one of the most encountered clinical condition in homeopathic hospital of India with 60.3 to 82.3% success rate. But only a single blind randomized placebo controlled trial with 50 millisimal potency and another observational pilot study with classical homeopathic treatment were available in literature, which revealed promising treatment effect. Now, the aim of our study was to evaluate the efficacy of individualized homeopathic medicine in case of hemorrhoids. The primary objective was to detect the difference in anorectal symptom severity and quality of life total score between IHM that means individualized homeopathic medicine, and placebo group over the 3 month of intervention. Secondary objectives were to detect difference in ARS's quality of life subscale score and bleeding, pain, itching, heaviness, mucus discharge, and swelling numeric rating score between IHM and placebo group over 3 months of intervention, to detect difference in European Quality of Life questionnaire and VAS score between IHM and PL group over 3 months of intervention, to detect difference in IHM and placebo group by the score of modified Naranjo criteria, to detect difference in IHM and placebo group by using Pratt-Hort score. The study was conducted in the outpatient department of State National Homeopathy Medical College and Hospital, Lucknow, and it was a randomized, double-blind, placebo-controlled true parallel clinical trials with 140 patients. We used permuted block randomization method to generate random sequence in 1:1 ratio. This study was double blinding, so masking of patient and investigator, also the outcome assessor, pharmacist, and data entry operator were done. Allocation concealment was maintained by using identically coded container having alike vials of either medicine or placebo. And each and every patient was given a follow-up at every fortnight or month per month. All the outcomes were measured at baseline and every month up to 3 months. The total study duration was 18 months. We registered the trial in CTRI prior conducting the study. Each and every patient got information sheet in local vernacular Hindi, and after that, written informed consent was taken from there. We recorded intercurrent illness, acute exacerbation of chronic condition, adverse or serious life events, if there are any, and were treated as per the homeopathic principle, irrespective of assigned codes. Now, we included those patients in our study who are suffering from primary hemorrhoids with or without NITs for at least 3 months. The patients were aged between 18 and 65 years of age, and both male and female patients were participated. Patients who are taking any kind of standard or other alternative therapy for hemorrhoids, they advised to discontinue for at least 2 weeks prior enrollment into the study. We included all the literate patients and who are able to read and write English, either English or Hindi. And with those patients are included who are capable and willing to give informed consent to participate into the study. We excluded grade 4 hemorrhoid patient, anal fissure, fistula, and hypertrophic anal papillae, inflammatory bowel diseases and coagulation disorder, rectal malignancy, suffering from those who are suffering from uncontrolled systematic diseases or life-threatening illness, any kind of organ failure, psychiatric disorder, pregnant and lactating women undergoing any kind of homeopathic treatment for chronic disease within last 6 months. The study outcomes were, primary outcome was ARS's quality of life total score, and the secondary outcome were ARS's quality of life subscale score, ARS's quality quality of life NRS score, EQ55L questionnaire score, and EQ55L VAS score, modified Naranjo criteria, and Pratt-Hort score. Now we have two arm. One was experimental arm, that is those patients who got individualized homeopathic medicine in centesimal potency with individualized dose as per the judgment of the susceptibility of the patient, and this was judged by the doctor, and subsequent prescription were also generated as per the Kent observation and homeopathic principles. The comparator arm, that is the placebo group, they received placebo indistinguishable in appearance from the verum. We advise all the patients from both the arm in the experimental and comparator group few lifestyle modification changes, just like cease bath and avoid unhealthy defecation habits and take fiber rich diet to encourage consume of adequate water, etc. So now come to the result. We approach ITT approach, that is intention to treat analysis, and our study attrition rate was 12.9%, while 120 patients completed the entire tenure of the trial. No significant difference were found in baseline comparison of two groups, so the data were comparable. We found statistically significant differences in ARS's quality of life total score, psychological impact, and concern subscale score. Also, EQ5D5L questionnaire score and VAS score. ARS's quality of life and Naranjo score had a negative correlation in both the groups. That means once while ARS's quality of life score is increasing, that means decreasing, Naranjo score is increasing. And in the same thing, ARS's total score and Prathod score also reveal negative correlation. The group differences were made with the Naranjo score and Prathod score significantly. The most commonly encountered medicines were sulfur, natramure, lycopodium, arsenic, and phosphorus. This is the graphical presentation of our primary outcome, ARS's quality of life total score over the time. You can see the IHM group and also the PL group, how changes takes place. Now come to the strength of our study. The main strength was that it is the first study of efficacy trial on homeopathy on hemorrhoids with individualized homeopathic medicine. One standard validated disease specific outcome, that is ARS's quality of life, and generic outcome scale, that means EQ5D5L questionnaire was used, and the homeopathic specific outcomes measures like Naranjo and Prathod scale score also used. We calculate missing values by regression to mean technique. Correlation statistics of changes obtained on both disease-specific and homeopathic-specific outcome measures showed strong correlation. As the trial was double-blind and randomized, so I think patient selection bias, evaluation bias, and data analysis bias could be minimized by this study. The weakness of this study was the duration of follow-up can be larger. Sample size calculation is based assumption because there is no prior study, prior RCT on hemorrhoids. And due to, as you all know, the COVID-19 pandemic, the availability and compliance of patient was compromised to a large extent sometimes. Now, I would suggest future research. Those strong correlation were found between disease-specific and homeopathic-specific. Disease-specific means ARS's quality of life, and homeopathic-specific means Naranjo and Prathod score, but it was non-significant. So, further studies can be made to address the issues. Now, the take-home message is individualized homeopathic medicine produce significantly better effect than placebo in treatment of hemorrhoids. Thank you for your patience listening.
Thank you, Dr. Munmun, for the wonderful presentation in spite of certain technical difficulties. Now I invite Dr. Josh for his expert opinion.
This was a very interesting presentation.
Thank you, sir.
The first of its kind study done in hemorrhoids. I just want to ask something about like your diagnosis of primary hemorrhoids. So could you enlarge a little on that? What would come within the purview of primary hemorrhoids?
Sir, it was diagnosed clinically, of course, but few patients were there who are already diagnosed cases. But most of the time we diagnosed it clinically because there is no availability of surgeon in our homeopathic hospital, as we all know.
Okay. So the thing is like, because you have ruled out grade 4 hemorrhoids also.
Yes.
I think you will have to rule out, if it is bleeding, then you'll have to rule out other conditions which can contribute to perirectal bleeding also. That's why I thought of having a little more clarity regarding the diagnosis, because often we as homeopaths are questioned on our diagnosis. And then the other things are our statistical study, our sample size recruitment, all these things we look into very closely. But people ask questions on like whether you examined the patient, whether you have diagnosed the case properly, and then because you have told about ICD also, that I can understand very clearly the diagnosis criteria you have mentioned. But even then, because you have told about pain, bleeding, different symptoms you have mentioned. So like if you, that's why I thought a little more clarity would be helpful for the others also to understand.
Sir, sorry to interrupt you. Actually, sir, if there is much bleeding was there, we or send them to surgeon for any kind of rectal malignancies and this kind of things. But most of the cases, because we have very little infrastructure in homeopathy to do something, so we have to do it. And we all know that COVID-19 pandemic was a very big challenge for those who are doing RCTs. I know sometimes we called the patient because please Ajaye, please come to for follow up. So it was challenging.
Yeah, and one more thing, like I just wanted to ask is regarding this scoring you have mentioned, ARSS QL score, you have mentioned about the total score and the subscale score. Is there any, like, could you just clarify it a little, like?
Sir, anorectal symptom. Whenever I was thinking about the study. So first of all, I search in the literature for any kind of disease specific scale, because I want to use disease specific, pile specific questionnaire. But there was no questionnaire is available there. So we formed it. Anorectal symptom severity and quality of life questionnaire. We formed it in NHMC Lucknow, and after that we validated. The paper is in press. That's why I cannot show you. So once it will published, it will be validated. Already it is in queue, and after that we conduct the study. And there is
well appreciated like step forward to form a criteria by yourself. And only one more small question, that is, did you have to have any give any lower potencies or tinctures during like adverse events, severe bleeding?
No, sir. We did not use any kind of mother tincture, because we only use individualized homeopathic medicines and sisbath. And I think phosphorus plays very good in piles, and I think almost 50 to 60% cases, because it's very huge. Phosphorus shows very huge efficacy in bleeding piles in case of.
Okay.
So we did not use any mother tincture.
It's a promising presentation anyways. Thank you.
Thank you, sir.
Thank you. Now I invite Dr. Sanjay Modi to present a study on arsenicum album and camphora for COVID-19 as a prophylactic. Over to you, Dr. Sanjay.
So a warm welcome to my presentation on study of arsenic album and camphora in COVID-19 as a prophylactic, a randomized controlled trial. I am Sanjay Modi, an author of Accurate Homeopathy and Organon of Medicine. Just a dedication to our master, who gave an essential quality of a homeopath in aphorism 6, of being an unprejudiced observer who is well aware of the transcendental speculations. So why I did? The general population had hope from homeopathy during COVID-19 pandemic. Homeopathy was in the limelight when Ayush claimed that arsenic album will work as a prophylactic in safeguarding health from COVID-19 when the directives were followed. But a similar claim came from Shankaran in the media for camphor 1M as a safeguard. This created doubt and conflict in the minds of people and homeopathic practitioners as well. Hence, it was necessary to affirm the same without prejudice, the role of arsenic album and camphor as a preventive for COVID-19 in healthy subjects. The best way to achieve this objective was a randomized controlled trial. Study holds absolute relevance because of the time frame when it was done between June 2020 to December 2020, which coincided with the first phase of COVID-19 wave, because India was reporting maximum cases in September 2020 at that time. And study was done in 2 different locations in Mumbai, spread around 8 kilometers apart, belonging to 2 different socio-economic strata. And the bar chart, we can see there were around 893 participants, out of which 356 subjects received placebo, 353 subjects received arsenic album 30, and 184 subjects had received camphor 1M. So the eligibility criteria that was set were, inclusion criteria was the age group that we had was between 1 year to 81 years, and adult was around 719 subjects, whereas children were less than 18 years were 148 subjects. 25 subjects age had not been recorded by volunteers. Gender, male were 492 subjects, female were 400 subjects. Comorbidity, patients with comorbidities like hypertension, diabetes, joint problems were also a part of the study. There were around 64 subjects who had comorbidities. Exclusion criteria were immunocompromised persons, and diagnosis of active psychosis or severe cognitive impairments were not considered. So what I did, medicines were purchased from a registered homeopathic pharmacy in exactly the way they were distributed to avoid any personal bias. To maintain the blinding, the bottles were coded as 1, 2, 3 instead of the names in my clinic. 6 local volunteers were appointed and randomly handed over those coded bottles. They weren't aware of the name of the medicines. They were advised to distribute these homeopathic medicines randomly to the subjects in their close vicinities. after explaining the objective of the study, taking the subject's assent consent, and documenting their demographic data and coexisting medical conditions. The subjects were advised to follow Ayush protocol for administering medicine. That was 4 pills of size 30 by adults and 2 pills by children daily on empty stomach for 3 days. Same had to be repeated after 1 month. Subjects were also advised to follow Ayush COVID-19 protocol of maintaining social distancing, wearing masks, and frequent hand wash. The subjects were advised to report to government centers after reporting to local volunteers if they experienced any symptom resembling COVID-19. Volunteers were closely monitoring the subjects since they resided at the same locality till December 2020 for any side effects and or active symptoms of COVID-19. So what did I come to know? On analyzing by chi-square test, gender category showed that the proportion of male and female across the placebo, arsenic album, and camphor are equal. So groups are comparable with respect to genders, which we can see from table 1, where the male percentage falls between 52 to 58% and female falls between 42 to 48%. On analyzing by chi-square the age category group, it showed that the proportion of children, that is less than 18 years, is significantly lower in ARSALB compared to placebo and camphor group. So table 2 shows arsenic album is 10.5%, placebo would be 19.7%, and camphor was 24%. And on analyzing by chi-square test, comorbidity category showed that the proportion of comorbidity was significantly higher in placebo group compared to ARSALB and camphor groups. And table 3, you can see that arsenic album, it was 3.45%, and camphor was 7.6%, and placebo was 10.7%. And on analysis of the by chi-square test of the COVID-19 status, the proportion of COVID-19 positive cases across 3 groups are near about the same, which we can see from table 4, where it was 0.6% in placebo and arsenic album, and camphor had 0.5%. Now, this insignificant difference that was observed was by chance. What did I learn? See, based on the RCT results, following conclusions can be drawn. Because the study was only to estimate the efficacy of so-called genus epidemicus as safeguard from developing COVID-19 disease. Firstly, there were no observable side effects reported by subjects. Secondly, the role of natural immunity and precautionary measures undertaken by the subjects holds relevance, especially when this study finds that arsenic album and camphor made no significant difference as protective for COVID-19, since the proportion of subjects affected by COVID-19 was the same in all 3 groups, which can be seen from the pie chart, and we already saw in table 4. There was also no observable difference in the severity nor the course of the disease in patients who suffered from COVID-19 disease. To conclude, there are 2 possibilities that seem probable. Wrongly identified genus for this pandemic. If that is so, homeopathic profession has to clearly define selection criteria for genus epidemicus. Because in this pandemic, we saw that the remedy that covered most symptoms observed in many patients of COVID-19 became labeled as genus epidemicus. Therefore, the genus was already circulating even before COVID-19 came to India. Had you observed that? This, as per Hahnemann's directive, is speculative. According to Hahnemann, physician becomes clearer of genus epidemicus in pandemics only after treating several cases as more and more peculiar symptoms gets completed. This, as per Hahnemann's directive, is scientific. Secondly, we could be with a misunderstood and misrepresented concept of genus. If that is so, time has come that we realign with the scientific unbiased evidence. So the question that comes up is, how do we go about? There are 2 roles genus epidemicus can play. First, promptly treating those with active disease in the shortest time without complications. Genus epidemicus definitely helps here while treating active disease. It saves time in case taking and requires differentiating only few similar remedies. And we have all experienced this particular thing in the current COVID pandemic. And secondly, it is as a safeguard for healthy subjects. Now the puzzle is to decide the best safeguard when there are no symptoms, that is in healthy population. The logic that is used is what is true for the disease patient is true for healthy people. Because the disease we are treating in patients and the disease we are trying to avoid in healthy persons is the same. So same remedy works. To check the scientific validity of this logic, let us pass it through organon to see what it means actually. Nobody has thought about it, but we need to understand what are the implications of what we are doing. Firstly, we prescribe an artificial disease to a healthy person based on the symptoms of other disease patients. Now, as for aphorism number 17, cure happens by the removal of the whole of the perceptible signs and symptoms of the disease. When the disease is annihilated, Dr. Hahnemann writes, health is restored. Now, it clearly reads that disease and health cannot stay together at the same time. My concern here is that in treating healthy persons, we are breaking the barrier between health and disease as defined in organon. We also need to look at which disease gets annihilated when we cure a healthy person and how health gets restored in already healthy. While treating a healthy person, how can we explain the concept of health, disease, and cure as per aphorism 17? Either aphorism 17 has to be overruled or treating a healthy person seems illogical. Secondly, according to aphorism number 26, we all are aware about that particular thing, the homeopathic law of nature. A weaker dynamic affection is permanently extinguished in the living organism by a stronger one, if the latter is very similar to the former in its manifestations. From a scientific perspective, the question that comes up is, when a person is healthy, will there be a weaker dynamic affection? Actually, there can be no weaker dynamic affections. Otherwise, why will he be healthy? Now, in absence of a weaker dynamic affection, can law of similar prevail? To what will the remedy be similar to in a healthy subject? And what will be permanently extinguished in a healthy subject? When there is no weaker dynamic affection, what does a stronger dynamic affection do in a healthy person? The answer lies in aphorism 32, where Hahnemann says that the artificial morbific agent, which we term medicines, have the capacity to act at all times under all circumstances on every living human being and produces in him its peculiar symptoms, and that also unconditionally. Also in aphorism number 108, Dr. Hahnemann says that there is no more natural way of knowing curative power than to administer the medicines experimentally to healthy persons in order to ascertain what changes, that is symptoms and signs, is produced on the health of the body and of the mind. So according to Dr. Hahnemann, administering medicine to a healthy person results in proving of that medicine. Now the above questions have a bearing on the scientific aspects of genus epidemicus. When we connect all these dots, the concept of genus epidemicus for a healthy person stands on a shaky ground and needs re-examination with an open, unprejudiced mind. Because Hahnemann is very clear when he writes to the footnote on aphorism number 1, his mission is not, however, to construct so-called systems by interweaving empty speculations and hypotheses. Of such learned reveries, we have had quite enough. And now it's high time that all who call themselves physicians should at length cease to deceive suffering mankind with mere talk. World Health Organization, seems to be following Hahnemann's vision when accepting that HCQ remdesivir made no significant difference in altering the course of the disease in COVID-19 based on unbiased data and evidence. Since accepting mistakes is the first step towards its rectification. I have just put my observation of the RCT done and the conclusion drawn regarding the concept of genus epidemicus, the way Dr. Hahnemann did after reading Cullen's Materia Medica. So let us stand up to Dr. Hahnemann's expectation of true physicians and aim to leave a legacy of a scientific system that gives clarity, confidence, and pride in practicing homeopathy. In the end, I can just say, dare to be wise, I have to acknowledge, certain people who have helped me for the studies, Dr. Rupa, Mr. P.L. Jagtap, Clinera, Dr. Sapna, Mr. Amin, and all volunteers and participants who made this possible. No donation has been received from anyone, and there is no conflict of interest. I would love to have your feedback at sanjay7modi@gmail.com. And you can also watch me on a YouTube channel, Sanjay Modi Homeopathic Lectures. You can join me on Facebook and WhatsApp group too, because I believe together we can. And thank you for giving me such a patient listening, and God bless. Thank you so much.
Thank you, Dr. Sanjay Modi, for your wonderful presentation. I invite Chair Dr. Josh Matthew for his expert opinion.
It is an interesting presentation going deep into organon, different aphorisms, trying to correlate things. Few things I wanted to just clarify. One is regarding the protocol we have followed, like because you have mentioned it's an RCT. So you have told like about randomization. I think you mentioned that this way the vials were handed over randomly to, so that actually there's a little lack of clarity regarding what type of randomization technique was used, whether it was a block.
There were 6 volunteers actually in 2 different locations, because they were spread a little apart. And this was the time when COVID had just started, and there was a lot of panic around in everybody's mind. So we had to find somebody who were local residents. So we handed them. So there were 3 people in one location. There were other 3 people in other locations. So we handed them bottles of 1 number to one person, 2 number to another person, 3 number to the third person. And they were asked to put all the data when they were administering the medicines, to give them all the understanding of, the patients, whatever requirements that we had talked to them about. And after that, they recorded all the data with them. This data we had then collected from them.
So I could understand that. I was just worried, want a clarification regarding what type of randomization technique you have used. Because when you say an RCT, like you have told about code numbers 1, 2, 3. So how did you arrive at that? Like, did you have a block randomization or some SPSS score? Like,
it was just block randomization that we had gone into.
Okay. So
Yes,
that's not clear from that is one thing.
Right.
And regarding allocation, any other, like, how did you do the allocation part? Was it concealed or like that? Also, I wanted to just know. Because this is an RCT, because RCTs are
right. I understand.
Yeah.
No, in what terms are we talking about?
Like about allocation, like when we say about this methodology, protocol methodology, we say about randomization, we say about blinding, and then we say about allocation. So in allocation, like how they were, like it was a concealed allocation, or like what type of allocation?
It was concealed. They weren't, see, nobody was aware about that particular thing. And there was a concealed understanding about, giving the particular, allotting the medicines.
And one thing is regarding like these patients which you have studied, were they under any other Ayush immunobooster medications? Because have you mentioned about this anyway? Like people take CADA and other things also. So you have to.
That is correct. But, at that point of time, we had asked them not to do anything else except homeopathic medicines as a part of that.
Okay. And this is one finding which I wanted to share. Like
why I tell you is because at that time, everybody wanted homeopathic medicines on the contrary. So they were eager to have this particular thing. And when we told them that it will help them to prevent from this particular thing, they were all the more willing to probably take that particular thing. So we told them, don't do any additional thing, just take these homeopathic medicines.
So I was just.
There was already a willingness established prior to, our joining into that particular thing.
Okay. And then arsenic and camphor you have mentioned. So
yes.
Like here, this is our experience in Delhi. Like we have seen bryonia coming on top. So maybe there's a regional difference in like in understanding the.
No, sir, I'll talk to you. Look, bryonia was definitely a medicine even in Bombay, but it was, for those who were suffering from COVID-19. So bryonia definitely helped, and I think it was one of the major remedies that came up, because I have around 300 cases which I have treated for COVID-19 themselves. Okay. And maybe if I probably put it across, more than around 50 to 60% had received bryonia.
Yeah. And one very small thing regarding the concept of health, which we have discussed in the last few minutes.
Yes,
So
sir.
we say health, it's always a relative state of health we are talking about. It's not an absolute health. So that is something which is like very tricky to draw a fine line between.
Because, sir, my health definition will go by what Hahnemann talks to me about. Because we have a definitely understanding of what health is. So, as far as organon is concerned, Hahnemann has very clearly defined what health is. So we go from that particular thing where, the spiritual vital force within the body, it lives for the higher purpose of human existence. So there is a very clear definition that Hahnemann has put across. So we take only those guidelines to go ahead with.
Okay. So I think this is a step in the right direction. We can, I think, especially a discussion generated on genus epidemics, that is quite something new and very interesting. So we should take this up forward. Thank you for your presentation.
Thank you so much. Thank you. God bless all.
Thank you.
God bless.
Now, I invite Dr. Srishti Mahajan to present the effectiveness of individualized homeopathic medicine and Sebalcerulata mother tincture in cases of benign hypertrophy of prostate. Over to you, Dr. Srishti.
Thank you, Dr. Anurajesh. I'd like to thank Dr. George also for giving me the opportunity to present my work here. And also I'd like to thank all the coordinators for such a beautiful, organizing this session. I'm about to share my screen. Okay, so I'll give you a brief view of the study that we did. This was to study the effectiveness of homeopathy and a comparison between individualized homeopathic medicines and Sebalcerulata in cases of benign hypertrophy of prostate. It was a prospective control single-blind trial. So to start with, since we all know benign hypertrophy of prostate is the enlargement of prostate gland, which results in compression of the urethra and restricts the flow of urine to the bladder. So when such a compression occurs, it causes a lot of discomfort for the individual. So the symptoms that we usually observe are obstructive as well as irritative symptoms. So when we talk about the obstructive symptoms, it can be hesitancy, it can be poor flow of urine, intermittent stream, dribbling sensation, or poor bladder emptying, episodes of near retention where the patient feels that, okay, the entire bladder is not yet evacuated. Then in irritative symptoms could be like the increased frequency of urine where the bladder is irritated, or there could be nocturia, that is increased desire of urine at night, urgency, urge incontinence, and nocturnal incontinence may also occur. So when we decided to do, so we could, in the background, we could say that it is one of the most common issues that men face. And about 105 million people across the globe suffer from PHP. It is more common in men above the age of 50, and it is almost present in almost the entire population of the age group 80 to 90 years of age or above. So the aim of our study was to study the role of homeopathy and compare the effectiveness of individualized medicine and organ-specific Sebalcerulata. The objectives were to assess the change in IPSS score, in the International Prostate Symptom Score, ultrasonography, prostate-specific antigen, and quality of life in the samples and also individually in the two groups. So the investigations we used in the study were the International Prostate Symptom Score, the Quality of Life Index, the ultrasound readings, and also the prostate-specific antigen. So to brief you about the prostate symptom score, it was a score that was initially sort of established by the American Urological Association in 1992 and originally had 7 questions. It was at that time called the American Urological Association Symptom Index. Later, it was adopted by WHO as the International Prostate Symptom Score, and they added this 8th question of quality of life. So as a whole, it has 5 markings here, 0 to 5, where a patient has no symptoms in 0, and almost always has where we say 5. The scoring is 5. So the cases of mild will usually have a sum total of 1 to 7, and the severe cases will have a score of 20 to 35. Also, quality of life was rated from patient is very happy with his quality of life as 8, and feels miserable with his life due to these symptoms as 6. So the categories that are covered in IPSS score are incomplete emptying of urine, increased frequency, intermittent flow of urine, urgency, weak stream, straining, and nocturia. So we use subulcer lata as the control group and also as an assessment because I came across studies where individualized medicine was used along with subulcerulata with a placebo as control, but I did not find many studies where there was a comparison between the two. So we use subulcerulata, which belongs to the plant kingdom, as the control group. So this was a randomized control single blind trial done on patients from Delhi NCR, and they were screened in the OPDs as per the inclusion and exclusion criteria and followed up for 6 months. The inclusion criteria included men with signs and symptoms of BHP who reported to the OPD, who had ultrasonographic evidence of BHP and had an international prostate symptom score of more than 7. Patients who gave consent was important for the enrollment. So the exclusion criteria included PSA of more than 20, then people who smoked cigarettes, chew tobacco, or were into drug abuse or alcohol abuse were excluded from the study. Also, patients with some severe illness or uncontrolled diabetes and hypertension were excluded, so as to avoid any further complications in their health. Or patients who were interested in surgery in the next 6 months were also excluded from the study. Then we enrolled a total of 30 patients in the final group, and there were 15 were randomly allocated to subulcerulata and 15 were allocated to given individualized medicine. We used both descriptive as well as inferential statistics. So when we evaluated the symptoms, we found that the PET T test was found significant at 0.01 level of significance for patients in both groups. This significant PET T test showed that there was considerable improvement in both the groups. So it showed that homeopathy as a whole was very effective in treatment of BHP. Then when we found the correlation between before and after the experiment, we found that there was a significant correlation in all the groups except when subulcerulata and individualized medicines, when we found the correlation before and after, the quality of life did not show much significant correlation, but other values showed a very significant correlation, again establishing the efficacy of homeopathic medicines for the cases of BHP. So when we correlated the different parameters, we found that quality of life improved considerably when ultrasonographic readings improved in the patients as a whole. Also, the IPSS score would improve since the quality of life would improve, the symptoms would improve. Also, we found that IPSS score had a significant correlation with PSA as well. Yeah. So now when we analyze the study, we find that the parameters before and after the study for the overall samples, we find that the international prostate symptom score considerably decreased in patients after the study as compared to the score that was before the study, hence showing that the patients, the symptoms of the patients improved very much improved. And then when PSA was computed, we also found again that PSA levels improved in patients, that is the levels decreased, though it was not a very significant change, but it was a considerable change that could be further studied with a larger sample. Also, when we talk about quality of life, with the medicines as homeopathy as a whole, the patients were very satisfied with the way their life improved after, and the symptoms improved, and how they could better manage their sleep or better manage their symptoms after the study, after the medications were given to the patients. Then also, if we grade with ultrasonography grading was done, also we observed quite a bit of change in the ultrasound readings, and that is how we see that, okay, ultrasound also showed improvement in patients with, and there was a decrease in size of prostate in quite a few patients. So when we compare the two groups, like now that was an overall study. Now when we compare the two groups, we found that after the trial, okay, so before that, individualized medicines that were indicated most commonly were Baraitacab, Causticum, Conium, Ignatia, Lycopodium, Medorinum, Naxvomica, Pulsatilla, Selenium, and Sulfur. So these medicines were given on the basis of individual symptoms, and the potencies and repetitions were determined according to the individual requirement of the patients. Most all patients were given centesimal potencies. So now we see that both groups showed improvement in prostate PSA after the study. So yeah, it was like more or less similar for both the groups. Then when we talk about IPSS score, that is the symptomatic improvement was much greater in the individualized group as compared to the subulcerulata group. Hence establishing that we should, aim for more individualized medicines as compared to organ-specific medicines. Then when quality of life was also assessed, again, we found that patients who were given individualized medicines were much more satisfied with the quality of their life as compared to organ-specific subulcerulata group. Then prostate size was more or less similar in both the groups, though there was a better results were observed in, again, individualized medicine group. So when we talk about the improvement of different parameters and the total overall improvement, we found that about 80% of the patients showed total improvement, drastic improvement, and there was a slight improvement in about 6% patients. Prostate specific antigen decreased for 23% of the patients, and there was no change for 76% of the patients. The IPSS score decreased, it got better for about 86% of the patients, and the quality of life improved for when we talk about mild improvement and complete improvement, it was about better for 90% of the patients, and decrease in prostate size was observed in 36% of the patients. So we could conclude that overall 80% patients showed marked improvement, and all the four parameters improved more for the individualized group than for subulcerulata group, though there was an improvement observed in both the groups. The correlation coefficient before and after treatment was significantly different for these groups, and hence again establishing that there was a marked improvement. A significant shift was observed in correlation values of quality of life with age and PSA and ultrasound, and of IPSS score with PSA and ultrasound. Were not significant. A shift towards negatively skewed and negatively platykurtic showed an overall improvement in diagnostic traits in BHP. A decrease in the standard errors also shows an increase in efficiency of our trials. A common question that arises is that why did we not use per rectal examination? Is we did not want subjective errors to sort of decrease the quality of our study. Thank you.
Thank you, Dr. Srishti, for a wonderful presentation. May I now invite Dr. Josh Matthew for his expert comments.
Yeah, this again an interesting study to see. One thing I noticed regarding the studies, like you have told about a total sample size of 30. So
yes,
sample size of 30 where you have 15 on subulcerulata and 15 on the individualized homeopathy. So, but what I feel is that if you want to have a small sample size, at least you should have 30 in one arm. It would have been better if you could go for 30 plus 30, 60. That would have been a little more better for comparison, because 15 as a small sample in itself will not serve the purpose of a small sample. That is what I feel. That's just one
agreed, sir. Agreed.
Finding which I saw. Then in individualized homeopathy, could you enlighten which potencies came more more useful? Decimal.
So more useful were the 30
different medicines
potencies.
you have mentioned. Which all potencies, could you highlight which the 30, 200, or what potency were more useful in
So more commonly indicated potencies were 30, but there were medicines like ignatia and lycopodium that were used in 200 potencies with infrequent repetitions, like less repetitions. But most of the medicines like conium, baryta, were indicated and they were used in 30 potencies. And there were a few instances where we had to progress from 30 to 200 also.
Okay.
When
The
improvement
maximum,
stopped
you
at
have,
30.
so you have not gone beyond 200.
No, sir. It was not required since the age of most of the participants was much, so we did not want to go with high potencies.
Okay, and one more thing, like when you showed this slide about the PSA levels, I think you have mentioned around. Could you show that slide if possible? That
Yes, sir. Yes.
the value, I think the response or the PSA decrease was seen in very few patients. That's what I remember 23 or something you have mentioned.
So this one?
No. Before you have shown a table where PSA has found in how many patients and.
Yes, sir. This one.
This one. So PSA, no change. You had shown almost like 23 patients, and you have shown a decrease in 7 patients. So
yes, sir.
At the outset, or the outcome, you have shown there is a general change in the symptomatology. All this has been achieved. So
this assessment was for when there was a change of more than 3 units in the PSA level was when we would consider it to have been considerably decreased, because for the PSA level. So this assessment was on 0.3 units of change, for 3 units of change. Yes.
Okay. That's all. Thank you.
Thank you, sir. Thank you for your valuable comments.
Thank you. Now I invite Dr. Leena to present her study to evaluate the efficacy of similimum to modify anger and thereby reducing essential hypertension. Over to you, Dr. Leena.
Hello and namaste. Okay, so namaste and hello to everyone. This is my research on anger and hypertension. It's a single-blind randomized controlled trial to evaluate role of homeopathic similimum in modifying anger in patients of mild to moderate essential hypertension and thereby reducing blood pressure against standard care treatment for hypertension. As you all know, 95% of cases of hypertension are of essential hypertension, also known as idiopathic hypertension. 30% of the world population suffers from hypertension. It is the largest single contributor to global mortality. In untreated cases, life expectancy reduces to 50 to 60 years compared to 71 years in the population at large. The Framingham Heart Study tells us that from the age of 65, the lifetime risk of developing hypertension is about 90%. This diagram depicts Dr. Page's mosaic theory, suggesting the interaction of genetic susceptibility and environmental factors responsible for the development of hypertension. These are the behavioral factors for the development of hypertension. Essential hypertension is among the 7 psychosomatic disorders where mental etiologies were proposed since the 1950s. Studies conducted during the last decades reported a clear relationship between hypertension and psychological factors like anger, anxiety, and depression. Anger is the most basic emotion, varying from mild irritation to intense fury in response to feeling threatened or hurt. It has 3 components: physical, fight or flight response; cognitive, that is angry thoughts; and behavioral, where anger expressed either verbally or physically or just withdrawal. Anger comes from the reptilian part of our body, known as the amygdala, which is an excellent indicator of threats. Its main purpose is emotional and social processing. It causes the brain to react to the threat or fear before the prefrontal cortex can consider the consequences. Anger is a very interesting emotion, but it is least understood. Moreover, it is just the tip of the iceberg. There are often other emotions like embarrassment, guilt, fear, rejection, frustration, etc. hidden underneath. Not only that, unfortunately, anger is also poorly understood in current diagnostic practices. For example, in DSM-5, there are no axis 1 disorders that directly address the emotion of anger, unlike anxiety and mood disorder. Anger is a critical variable in essential hypertension. Unresolvable anger causes prolonged sympathetic nervous system overactivity. Anxiety and guilt of consequences of expressing anger results in suppression of anger. And in vulnerable individuals, neural mediation of repetitive high blood pressure episodes cause structural adjustment in arterioles, culminating in sustained hypertension. Anger could be contributing to the elevation of BP directly through psychophysiological activation and indirectly by facilitating the emergence of a coping style that contributes to the maintenance of elevated blood pressure. Here comes a question in mind. Can anger be quantified? Well, psychologists have developed different types of scales that measure anger and its components that give a fair idea of a person's state of mind and coping mechanisms that initiate the hyper response of the cardiovascular system in terms of raised blood pressure. STAXI-2, that is State Trait Anger Expression Inventory 2, is one such scale which is containing 57 questions, which is used by anger and cardiovascular researchers worldwide since 1995 and is validated and translated in many languages. We too have used it for our study subjects. Here, let me tell you, the state anger denotes the angry state, and trait anger denotes tendency to get angry. And with the advances in technology, modern radiological and biological measures like functional MRI are developed to visualize and measure changes in parts of the brain brought about by anger. Dr. Hahnemann described 3 causes of chronic diseases like hypertension: fundamental, maintaining, and exciting. He has also instructed to give the highest importance to mental symptoms while selecting a remedy for chronic ailments. Here comes our research. The research question is whether there is a relationship between components of anger and hypertension in the patients coming to our OPD. Our OPD is one was at Bombay, the other is at our rural hospital in Palghar, and at a factory at Daman. And second question was, does homeopathic medicine selected on the basis of case taking and totality, taking anger as a main clinical criteria in patients of mild to moderate essential hypertension, are more effective than the standard antihypertensives used by allopathics? The hypothesis being essential hypertension can be improved by better anger coping mechanism. There is a difference in values of anger in rural and urban participants. And third, patients with family history of hypertension are more prone to hyperreact to stressors and thereby more susceptible to hypertension. And fourth, there is a linear correlation between anger and hypertension. This is the consort diagram of our randomized controlled trial explaining the methodology. We screened around 350 patients of essential hypertension. Secondary causes were ruled out by checking routine blood biochemistry, ultrasound, cardiogram, and X-ray chest. And also patients with severe illnesses, endocrine or psychological, were excluded. 172 patients, that is 108 males and 64 females between 18 to 65 years who gave their informed voluntary consent, were enrolled in the study as per the ethics committee approval. By simple randomization, they were allocated their respective groups, that is placebo and intervention group. More than 50% of patients in both groups were on allopathic antihypertensives prescribed at the beginning of the study by the physician. All the patients were given necessary lifestyle management advice and DASH diet and regular exercises. Thorough homeopathic case taking was done, and the STAXI-2 scale was applied at the beginning and after a 6-month study period to measure the change in anger for all the patients. Regular follow-up was done every 2 weeks to evaluate the subjective and objective parameters. Data collected was entered in MS Excel and then transferred to SPSS version 21 for analysis. The quantitative data were represented as mean plus or minus standard deviation and compared using students' t-test. In addition, a Pearson correlation test was performed to find correlation between variables. Here comes the results. This table shows the analysis of different variables. There are 12 anger variables, and the last two is systolic and diastolic blood pressure. That shows the analysis of different variables done at the end of the study period 6 months, as seen in the table depicting the intervention arm. Except state anger and its subgroups, that is the first 4 variables, all other anger variables and systolic and diastolic BP have a statistically significant reduction denoted in p-value 0.001 in red with 95% of confidence interval. This slide shows the values in both arms, the purple being the intervention and orange is the control arm. And it shows that the values in both arms at the end of the study period, the values in the intervention arm show a much greater reduction in the values of all the variables compared to the control arm. In both arms, the patients who were on standard antihypertensives, in the control arm, 98% of patients continued with the same dose of their medicines at the end of the study period. However, in the intervention group, standard antihypertensives were stopped completely in 33% of patients, and in 28% patients, the dose of antihypertensive was reduced. At the end of the study period in both the arms, the patients who were not on standard antihypertensives, in the control arm, 16% patients had to be prescribed standard antihypertensives. Whereas in the right side, the intervention arm, the BP of all patients was maintained on similimum. Now we tested the hypothesis. The group analysis for difference in anger in rural and urban group was done in both arms. This is control group and this is an intervention group, where you can see that there was no statistically significant difference in p-values. So there was no difference in the anger in both the groups. Then we did the group analysis of the family history of hypertension in female participants. This suggests that women with a positive family history of hypertension scored higher on trait anger and angry temperament denoted in red. That means they have a higher tendency to get angry. However, they tend to suppress their outward expression of anger compared to participants having negative family history of hypertension. This also correlated with higher blood pressure values in them. Similar thing in men. Even in men with a positive family history of hypertension, they have higher trait anger denoted in red and angry temperament, meaning they too have a higher tendency to get angry like their counterpart, but tend to suppress their outward expression of anger than the participants with the negative family history of hypertension. Now, this is a very important slide, and one can proudly say that only we homeopaths can produce such results, and no other system of medicine can claim this. It shows the list of associated ailments these patients had along with essential hypertension like diabetes, acid peptic disorder, fibromyalgia, and so on. And at the end of study period, as you can see on the right side, the blue wheel, 89% of patients had relief in the symptoms of their comorbidities in the treatment group with the curative effect of the similimum. But 73% of patients, the red wheel, shows that the symptoms of associated illnesses were status quo in the control arm. Then we ran a Pearson correlation test to determine whether there is a linear correlation between anger variables and systolic and diastolic blood pressure. Unfortunately, in this study, like many others in the past, we could not find a significant linear correlation between anger variables and blood pressure. This is the list of homeopathic medicine that we have used in centesimal potency and 201 m, as you can see. So in conclusion, I would suggest that our results suggest the usefulness of the homeopathic similimum In the management of anger and the essential hypertension in the population, we found a significant correlation between high blood pressure and suppressed anger in male and female participants with a positive family history of hypertension. Convincing evidence did not emerge for the existence of a strong linear correlation between anger and blood pressure variables. This study brought to our notice that health-related consequences of anger have not been sufficiently studied, and this is the first ever study in homeopathy and even in psychiatry in India that has studied the anger and hypertension. It also revealed that psychosocial stress resulting in anger leading to risky behaviors like smoking, alcohol consumption, and unhealthy diet was highly prevalent and significantly associated with this disorder. The limitations and future direction, the study needs replication with a larger sample size over a longer duration. Presence of social desirability bias cannot be denied in a self-reporting scale like STAXI-2. Ambulatory blood pressure monitoring is not used. So misdiagnosed cases of white coat hypertension or cases of masked hypertension could have been missed. A double-blind controlled randomized controlled trial without using conventional antihypertensives is highly recommended. Thank you.
Thank you, Dr. Leena. My kind request to Chair to keep the remarks brief as we are running out of time.
I think most of my questions have been answered towards the end of the session regarding the previous studies and the verification of your 4-point hypothesis. So I'll just ask something about the stopping of hypertension medication in, like we have mentioned about the stopping of medication. So in both the arms, like how much time did you take for stopping medication? Or it was like any pattern you followed?
Yeah. Sir, it was actually this studies in collaboration with a physician in this thing. And the beautiful part was that within 1 month, we were giving infrequent doses, like twice a week, the medicine was repeated, just 1 dose. And then we also had, I have not, because of paucity of time, not mentioned over here the effect of homeopathic case taking in patients, because then we used to produce the insight in them about anger and the consequences, as well as we drew their attention to the situation where what they are facing and how they can come out of it. So that gave a very beautiful result, and within a month or 1.5 months, the blood pressure started reducing. And as you can see that by 6 months interval, 33% patient reported that the blood pressure was normal, and the physician totally stopped. Along with that, we of course gave them DASH diet, the dietary advice for the systolic hypertension and exercise. So that had given a very good result. And in fact, I would say, sir, that all these patients are still following up with me even after I have finished my PhD research. And most of the patients we have been able to stop their antihypertensives.
Okay, that's all. Thank you.
Thank you, sir.
Thank you. It would be highly appreciated if the next 2 speakers, Dr. Priyanka and Dr. Sana, can wind up their presentation in 10 minutes. So we get a quick brief comment from the chair. I invite Dr. Priyanka to give a presentation on efficacy of individualized homeopathic medicine in the treatment of hyperuricemia. Over to you, Dr. Priyanka.
Good afternoon, everyone. Is my slides visible?
Yes, it is.
Yeah. Greetings, everyone. My name is Dr. Priyanka Ghosh. I am a postgraduate trainee in DND Homeopathic Medical College and Hospital, Kolkata, West Bengal. My topic of presentation is efficacy of individualized homeopathic medicines in treatment of hyperuricemia, evaluation by double-blind randomized placebo-controlled trial. Moving on with the introduction, hyperuricemia is a major health issue in India as well as all across the globe. It is well characterized by the increase in the blood serum uric acid levels, which may form sharp crystals in the form of monosodium urate and may produce one of the commonest manifestations of hyperuricemia as gout. Hyperuricemia is also closely related with several other diseases such as diabetes, hypertension, obesity, and many other diseases, cardiovascular and the renal disease also, which increases the disease burden and hampers the quality of life. Concerning all this, this exploratory trial aimed to evaluate the efficacy of the individualized homeopathic medicines against placebo in treatment of hyperuricemia. Regarding the aims and objectives, the specific objective was to evaluate the efficacy of individualized homeopathic medicines in comparison with placebo in treatment of hyperuricemia. And the general objectives were to determine the group differences in the serum uric acid levels, in the hyperuricemia quality of life questionnaire scores, as well as in the measure yourself medical outcome profile 2 version scores over the 3 months. Also, to shortlist the most frequently indicated homeopathic medicines in the treatment of hyperuricemia. Concerning the methods and materials, it was a double-blind randomized placebo-controlled 2 parallel arms trial which was conducted in the outpatient department of DND Homeopathic Medical College and Hospital. As no formal sample size calculation was possible, so we assumed an effect size of 0.792 with a study of 54 patients with the 80% power and having a significance level of 5%. Further, giving a 10% attrition rate, we targeted the sample size as 60. Our study duration was for 18 months, and the study protocol was approved from the Institutional Ethical Committee, which was further registered prospectively in the Clinical Trials Registry of India. In the inclusion criteria, there were patients aged between 18 and 65 years of age who were suffering from hyperuricemia for the last 3 months. It means for the male, it was the serum uric acid level should be above 7 milligram per deciliter, whereas in case of women, 6 milligram per deciliter was there. The literate patients were included as I have the questionnaires which the patient has to self-administer and to fill themselves. That's why the literate patients were taken and who were willing to give the written informed consent. The cases of overt hyperuricemia, secondary gout, or any advanced cases which would require any surgical procedures, unstable mental or psychiatric illness, or the patients, those who were currently receiving any kind of homeopathic treatment, were also excluded from the study. The self-reported immunocompromised patients, women, puerperal, and lactating women were also excluded. In the outcomes, I have got two outcomes. In the primary outcome, there was serum uric acid level, which was noted in the baseline and every month up to 3 months. In the secondary outcome, there were two questionnaires. First is the hyperuricemia quality of life questionnaire, which is having 5 components and it is derived from the gout assessment questionnaire. Second is the MyMop2 or the Measure Yourself Medical Outcome Profile 2 version, which consists of 4 components. A mean of the 4 item score is calculated and is referred to as the MyMop2 profile score. Regarding the timelines, all the outputs were recorded at the time of enrollment, that is in the baseline, and every month the patients were called up to 3 months. Intention to treat analysis approach was used, where in the intragroup differences, one-way repeated analysis of variance was used, and for the intergroup differences, two-way repeated measure ANOVA was used. Also, the unpaired t-tests were used. This is the consort flow diagram. 94 patients were screened out of which 60 meet the eligibility criteria, and they were randomized and enrolled into 2 groups, one in the experimental arm and another in the placebo arm. In the experimental arm, those received the individualized homeopathic medicines according to the constitutional totality past history, and the medicines were prescribed in the centesimal potencies only. In the placebo arm, identical looking placebo was given. In both the arm, concomitant care was provided, that is, dietary management was given in both the arms, which included lacto-vegetarian diet, moderation of the high purine diet, and intake of fluids. After the follow-up, it was found that 58 patients could be evaluated from the intention to treat analysis approach. The results were as follows. Between the group difference in the serum uric acid levels and the hyperuricemia quality of life scores and the MyMop2 profile scores, in both of the 3, we can see that the results were statistically significant, which favored the individualized homeopathic medicines against the placebo with medium to large effect sizes. Among the 26 prescribed medicines, Calcarea carbonica and Pulsatilla nigricans were the most frequently prescribed medicines. Moreover, I have prescribed it in centesimal potencies, so 30 and 200 potencies were frequently used. No harms or serious adverse events were reported from either group. Discussion. My strength of the trial was that it is a randomized trial and double blind, which followed the consort and the red hot guidelines. The choice of an objective measure, that is the serum uric acid level, as the primary outcome, and a pre-validated disease specific quality of questionnaire, that was the hyperuricemia quality of life questionnaire, along with the generated patient reported outcome measure, further strengthened the trial. And as it is was a small duration trial, so yes, we can say it has its limitation. Plus the COVID-19 pandemic situations resulted in the 6 dropout of patients. My future research will be that independent replications are definitely warranted, and in this case I have used only the centesimal potencies. Maybe in future, in the same way, 50 millisimal potencies can be used to come at a conclusive recommendation of use in the individualized homeopathic medicine in the treatment of hyperuricemia. Finally, I would like to conclude that in this randomized placebo, double-blind placebo-controlled trial, the individualized homeopathic medicines definitely produce significantly better effect than the placebo in reducing the serum uric acid levels. And not only it targeted in reducing the serum uric acid levels, but also it helped in improving the quality of life of patients suffering from hyperuricemia. But further independent replications are warranted. This trial has been submitted in the Journal of Homeopathy and it is under review. So I would like to conclude my presentation. Thank you.
Thank you, Dr. Priyanka, for such a wonderful short presentation. Dr. Josh Matthew for his expert opinion.
Yeah, the presentation is such very short and very precise, covered. I think the protocol, everything was covered very nicely. Only one question. This is actually a technical question. Like when you're doing a PG, you have a difference between what is effectiveness and what is efficacy of a study. The terms used, like I've seen,
sir.
like used almost synonymously. But is there a difference between effectiveness study
Yes, sir.
and efficacy study?
Yes, sir. There is definitely a difference between the efficacy and the effectiveness. The efficacy is only done in an ideal, like in the situation where we cannot mold from anywhere. But the effectiveness, we can do our study according to the environment. Efficacy doesn't include that of only a placebo group. The efficacy only involves that we are doing our trial under our study protocol. We cannot mold from this, but in effectiveness, it can be according to the situations we can mold.
Okay, that's all.
Thank you. I invite
you,
this final speaker for this session, Dr. Sana. She'll be presenting efficacy of individualized homeopathic medicine in plantar fasciitis.
Good afternoon to everyone from India. I hope you're all doing well. I'm going to give my presentation on efficacy of individualized homeopathic medicines in plantar fasciitis, a double-blind, randomized, placebo-controlled clinical trial. So what is plantar fasciitis? It is the most common cause of foot pain in OPD, which results from constant strain in plantar fascia and its insertion into the perial tubercle of calcaneus. It affects around 1 million patients per year, which include around 10% of injuries in runners, 11 to 15% of foot symptoms that require professional care, 10% of the general population are affected, of which 83 are active working adults, aged 25 to 65 years. And it has a high economic cost. Now, we did a systematic review with meta-analysis and found that some interventions were effective in comparison to placebo. The homeopathic medicine thiocyanabinum was helpful in recent cases of PF as compared to thiocyanabinum and Mercor or thiocyanabinum and Mercbin iode prescribed together. Root prevalence was found effective in one study. A retrospective study was carried out in patients with heel pain, and it found homeopathy to be useful. Several case studies by Dr. Nash and Dr. Kent showed medorinum, rustox, ledempol, pulsatilla nigricans to be helpful. However, the analysis could not reach any definite conclusion as the improvements were very small, had methodological flaws, were underpowered, and poorly reported for many of the interventions. Now, we started with the research question. can individualized homeopathic medicines produce different effect from placebo in the treatment of plantar fasciitis? Null hypothesis was that there will be no difference in the change of foot function index between IHM and placebo group after 3 months of intervention. Alternative hypothesis was that there will be significant difference in the change of FFI between IHM and placebo group after 3 months. Now, the trial design was prospective, randomized, double-blind, placebo-controlled, 2 parallel arms clinical trial. Study site was OPD of Mahesh Bhattacharya Homeopathic Medical College and Hospital at Howrah in West Bengal. It was approved by the Institutional Ethical Committee and was registered in Clinical Trial Registry, India. And the participants' inclusion criteria was that cases that were suffering from PF for a minimum of 3 months, had not undertaken any treatment for the past 2 weeks, aged between 18 to 60 years, either sex, literate patients who could read Bengali, given written consent to participate, and willing to take only homeopathic medicines. Exclusion criteria included cases suffering from uncontrolled systemic illness or life-threatening infections, calcaneal spur or any bony deformity or foot pathology, undergoing homeopathic treatment for any chronic disease, substance abuse and or dependence, pregnant or pubertal or lactating women, psychiatric diseases, and self-reported immune-compromised states. The trial protocol and full dissertation was submitted as my postgraduate thesis to the West Bengal University of Health Sciences. Now, what was the intervention? Patients were randomized into 2 groups. The experimental arm received indicated homeopathic medicine in centesimal potency, and the comparator arm received a placebo, which was indistinguishable in appearance from Virum. The dosage and repetition were as per the case. Placebo prescription was similar to Virum and blinded for patient, prescribing doctors, and outcome assessor. Now, all the participants were advised to have a contrast bath, foot exercises, and use of shoes made of microcellular rubber. Now, the outcome measure was foot function index, which is a numerical rating scale of 0 to 10, having 3 domains, and the minimum. Sample size is formal effect size calculation was not possible due to lack of any published trial of a similar design. We were able to enroll 75 patients only. So post-hoc power calculation revealed a power compromise of up to 57%. Randomization was done as per the randomization chart prepared by an independent third party. Star Trek generator was used. Blinding, double blinding was done. Allocation concealment, identically coded containers labeled 1 or 2 was used for either medicine or placebo, assigned as per the randomization chart. The codes were broken at the end of the trial after the data set was frozen. Now, statistical method, intention to treat approach was taken. Missing values were replaced by the series means. P-values were set at less than 0.05 as statistically significant, and the statistical analysis was done using SPSS version 23.0. Now, the intervention was in strict adherence to the classical homeopathy principles, and it conformed to the Declaration of Helsinki. It complies with consort and Red Hat guidelines. Of the study flow, 328 patients were screened, 253 were excluded, due to various causes. As you can see, illiterate, denied consent, uncontrolled HTN or DM, already undergoing homeopathic treatment, having foot pathologies such as calcaneal spur and others, best CA with skeletal metastasis, and pregnant and lactation. So 75 patients meeting the eligibility criteria was enrolled. Baseline socio-demographic outcome data obtained. Participants were then randomized into either Verum or control as per the random number chart. Outcome data recorded every month for 3 months of intervention. Now, 7 patients dropped out during the study, 4 in the Verum arm and 3 in the control arm. 68 were able to complete the study for 3 months. The study duration was 18 months, October 2018 to April 2020. And we did a follow-up for 3 months. And being a postgraduate thesis, the trial could not be extended beyond May 2020. All the randomized patients entered the final analysis, that is 37 in the Verum arm and 38 in the control arm. Now, the socio-demographic profile was similar. at baseline. Total foot function index and the 3 subscale percentage scores at baseline was significantly higher in the IHM group in comparison with placebo. All p-value less than 0.01. Intra-group changes in FFI scores after first, second, and third months of intervention reveal significant improvement in both the IHM and placebo group. All p-value less than 0.001. Differences between groups every month favored IHM significantly against placebo. After adjusting for baseline differences between groups in total foot function index and the subscale percentage score using ANCOVA model, two-way repeated measures ANOVA also revealed a statistically significant difference, favoring IHM against placebo. 25 medicines were prescribed in the 30, 200, and 1 potency. The most prescribed medicines were natrum mu, Rustox, rutagrelulins, and natrum sal. Adverse events, none reported. Now you can see the diagram over here, showing the changes from baseline to first, second, and third month in the Verum arm, IHM group, and in the placebo group. And these are the 21 medicines prescribed in the Verum group and in the placebo group. Now discussion. Though the sample size of the study was less, it was still adequately powered to detect changes. The treatment was in adherence to the principles of homeopathy. Retention rate was promising, but the recruitment rate was low. Being a placebo-controlled trial, recruitment was quite challenging. Before using it in the trial, we developed the Bengali version of FFI questionnaire. The findings will be reported elsewhere. A significantly higher baseline pain score was seen in IHM in comparison with placebo. Occurrence of PF was greater among females than males. Increased incidence of PF in individuals above 30 years of age was observed, which corroborates one study with an increased incidence among young and working women. High BMI of significant proportion of our sample was seen, which corroborates the study where obesity was confirmed as a risk factor for PF. Intragroup changes over first, second, and third months of intervention reveals significant improvement in both the Verum and control group, which supports the finding that stretching exercises improves pain due to PF, as both the groups had received conservative management. The study revealed the increased prevalence of calcaneal spur in patients with foot pain, mostly bilateral, and that it can be treated with IHM. Are the strengths of the study? Randomization, double-blind, prospective, placebo-controlled with conservative management, followed CONSORT and Red Hot guidelines, adherence to the principles of homeopathy, attrition rate 9.3%, and the choice of FFI in vernacular Bengali as the primary outcome measure. Limitations were small duration, 3 months, low recruitment rate, outcome measures amenable to subjective biases of the patients. Now, the unanswered questions and future research. A similar study with a larger sample size may be done in future. A multi-center approach should be adopted. A longer duration of study for further insight into the recurrence of the complaints. Inclusion of investigation parameters such as MRI to detect the actual thickness and changes in plantar fascia for better understanding of underlying pathology. Or the conclusion, IHM showed significantly better results than placebo in PF with large effect sizes. However, independent replications are warranted. This is the altmetric score, around 66. It's in the 97th percentile. This is the top 5% of all research outputs ever tracked by altmetric. This is the publication in homeopathy on September 7, 2021. It's available at this site. You can read it from here. Index in PubMed. Thank you. Thank you to the organizers at LMHI Global Colloquium for organizing such a wonderful program, for giving me this opportunity to present this.
Thank you, Dr. Sana. I invite the chair for his comments for Dr. Sana as well as his concluding remarks.
Okay, thank you. This again, PG thesis converted into a very interesting study. Only 2 points I wanted to clarify. One is regarding when you say plantar fasciitis, what was your, like, was it a diagnosis of exclusion or like how exactly you zeroed in on plantar fasciitis? Because I think you have mentioned about you have excluded calcanean spur and other things. So
Yes, sir.
because MRI, I don't think MRI was done in all cases. So like, how do you zero in on your diagnosis of plantar fasciitis?
So basically, it was a clinical assessment.
Okay. So like, because you have calcanean spur is ruled out, and then the other
Yes,
one.
sir. Yes, sir. X-ray was done in all the patients.
And about like the potencies used, I think the maximum I've seen is 1 m.
Yes, sir.
You didn't feel a need to go about beyond that, or like you got the result you are expecting within 1 m.
So result I was expecting within 1 m plus in the time duration of 3 months, I could not go beyond that also.
Okay. That's all.
Thank you, sir.
And one more thing, this is sorry, that's not related to you. So it's general comments on this session. I think this RCT session is a very interesting session. So we can see homeopathy going in the proper direction of. So earlier, people thought that homeopathy and RCT won't go together. Now I think very clear individualizing homeopathy management along with RCT correlation has been seen in a lot of cases, and very encouraging to see that this PG thesis have come into such a level where you can see the exact rigor of RCT being followed. That is one thing. And even very interesting to see that the presentation of that COVID presentation, where a lot of questions came up about genus epidemicus and anger also. I think something which we don't touch in detail when you go. And I think this anger study can be taken up in relation to specific drugs, like when you have guilt, and you can think about Strepsagria or other lot of drugs will come in across when you can see how they can be correlated in that way. So this is very interesting, and I'm very happy to be a part of the chair to be able to share my experiences. Thank you.
Thank you, sir.
Thank you, Dr. Josh Matthew, for accepting our invitation to chair this session and for your valuable comments. Thank you to all the presenters, delegates, coordinators, and organizing team. I may now request everybody to switch on the video for a photograph.
Done, ma'am.
Thank you.
Thank you.
Thank you, everyone.
Thank you all. God bless.
Thank you, everyone. Wonderful presentation and so well coordinated. Thank you, Dr. Anu. You were really you're a really very awesome moderator. You've done a wonderful coordination. Thank you so much for it. And to all of you, have a lovely day ahead. And thank you so much. I'm looking forward to see you again.
Thank you all.
Thank you, ma'am. Thank you.